So let's shift our attention now away from hypothesis testing and towards forward thinking and pattern recognition, the two other forms of clinical problem solving we want to talk about today. And I want to reference a really important article that is well worth your time reading, written by Judy Bowen and published in the New England Journal in 2006, where she talks about clinical problem solving and the importance of problem representations as the key to really effective clinical problem solving. And forward thinking and pattern recognition require and use better problem representation to generate differential diagnoses that are shorter, more relevant, and easier to handle than does the clinical problem-solving tool of hypothesis testing that is commonly used by novices and in ultimate problem-solving failures. So problem representation really means a way of describing a problem as fully as possible and as specifically as possible before you start generating a differential diagnosis list. It's important when you represent a problem, that is, provide a comprehensive view of the patient's condition as they're presenting, that you incorporate all significant symptoms and signs, describe them as accurately as possible, emphasize the most specific features, that is, the ones that will help you rule in or rule out one disease, and avoid distraction by minor signs or symptoms or nonspecific markers of illness. It's also important that we want to try and develop a problem representation that allows us to effectively match the patient's representation to the classic disease descriptions we've talked about as illness scripts. There are two steps to problem representation. One that we'll focus on today, processing, and one that will be the subject of next week, which is the patient illness script. Processing involves the abstraction of patient complaints into medical language, and we'll talk about why this is so important. It is a beginning step in problem representation. And then a patient illness script is combining those abstract medical descriptors of the patient's signs and symptoms into a summative statement that looks a lot like a disease illness script and facilitates our ability to compare the patient's presentation to some of the diseases we're considering in our differential diagnosis. Processing. You're going to spend a lot of time with processing today and in the homework this week. It involves translating lay language, the patient's signs or symptoms as they describe them, into more abstract and potentially descriptive and specific medical terminology. And there are several good reasons to do this. The first is to play as you practice. When you translate a patient's lay language into medical terminology, it facilitates the activation of the memory stores in the way in which you learn them. So when you go to class in medical school and you learn about dyspnea, you store information about dyspnea in your brain under a file known as dyspnea. So when a patient presents with shortness of breath, from a cognitive perspective, it's better to translate it into dyspnea so that your brain can activate those memory stores. Secondly, it helps you seek information in medical resources. You can't look up the phrase shortness of breath in Harrison's or Cecil's or current medical diagnosis and treatment, but you can look in the index and find the term dyspnea. So it's a very practical reason for translating the patient's language into medical terminology. Thirdly, it supports compare and contrast thinking. So it helps you identify and precisely define the patient's symptom so that you know whether you're dealing with dyspnea that's acute or dyspnea that's chronic, and that helps activate those memory stores that we talked about in the disease-related illness scripts. And most importantly, it increases the efficiency and precision in diagnosis by incorporating much more robust and complete representations of the patient's problem in a shorthand way that facilitates diagnosis. Most process terminologies are what we call abstract, so they move from the patient's description of "I have been sick for a day" to more abstract concept we talked about last time. When we talked about time, I've been sick in a hyperacute fashion, very short period of illness. And they're oppositional, so something can't be both acute and chronic. It's either acute or chronic. So we begin to get into that forward thinking mode as we think about a series of branch chain points that each question takes us along that path. So a very common one, and we talked about time as a critical element to the disease illness script, it turns out to be a very critical element to the patient illness script. And these are 4 descriptors that we commonly use in terms of the duration of the symptom that the patient is presenting with. So a hyperacute presentation is one that happens in minutes to a day, minutes to hours. An acute presentation, a couple of days. A subacute, a couple of weeks. And chronic, months. This turns out to be very, very helpful. And we talked briefly about that when we used our example of meningitis in the very beginning of this course. But here's another example. If you look at this red circle as the sum total of diseases that cause diarrhea, you can break it down into the types of diseases that cause chronic diarrhea, the types that cause acute, and the types that cause hyperacute. And in fact, if I know my patient has had diarrhea for 4 months, I know I no longer have to consider the diseases that only present with acute diarrhea or hyperacute diarrhea. So I have already decreased my workload and my cognitive load by eliminating a whole subset of diseases that I no longer have to pay attention to. And I can turn my entire attention to all of the diseases that cause chronic diarrhea. There's still a lot of them, but much fewer than if we had to consider these other diseases as well. Processing can also involve the use of qualitative descriptors. That is a way of translating the patient's symptom into a term that's recognized in the medical community as a very precise way of describing that symptom. Again, it's abstract because it moves from the patient's description, which might be very colorful, but hard to compare to another individual's same description of a similar finding, until we translate that into medicalese. So if I say that my limb is weak, and my sister also feels weak, but she says it's heavy, and I think it's the same phenomena, I can call both of those evidence of paresis. If, on the other hand, my patient says I can't move, then I'm going to say that the person has a form of plegia. If they have some numbness, that's not the absence of sensation, but just a funny sensation, I might call that dysesthesia. And pins and needles might be paresthesia. There are many forms of qualitative processing for different signs and symptoms. We're just using neurology today as an example. There's also distributive processing. So we talked about time-based processing, acute, hyperacute, chronic, qualitative processing for neurologic symptoms, paresis, plegia, paresthesia, dysesthesia. And now we're going to talk about distributive processing. And distributive processing says where in the body are these processed qualitative descriptors occurring. Hemi, one side of the body, para, lower aspect of the body, tetra, all 4, or mono, single limb. Again, what you see, this is sort of a shorthand for the physician. Instead of saying they have weakness in their leg, arm, left leg, and left arm, they can say they have tetraplegia. And it's instantly recognizable not only to their memory stores, but to the memory stores of any clinician with whom they interact. That's descriptive processing, time-based, qualitative-based, and distributive-based. Let's move on now to summative processing. Summative processing recognizes the existence of a described syndrome in medicine. It's very rich communication shorthand. It instantly conveys tremendous information, often many simultaneously present signs and symptoms. And in doing so, makes it easy to understand what's going on when clinicians are talking to each other, but also importantly prevents overemphasis of a single symptom. So if a person has one symptom, we don't want to pay attention to that and ignore the other ones that might show that that symptom is part of a bigger whole, or underemphasis of a constellation of symptoms. Here's an example of classic summative processing, and this is a series of linked but slightly different conditions related to cardiovascular compromise and or infection. So the first is the syndrome of SIRS, or systemic inflammatory response syndrome. And those patients have a constellation of signs and symptoms: fever or hypothermia, tachycardia, increased heart rate, increased respiratory rate, leukocytosis, leukopenia, or bandemia. If I, as a clinician, am examining a patient and looking at their labs and notice that all of these things are present, rather than listing them individually and trying to figure out what each individual sign or symptom is caused by, I can put them all together in one syndrome, communicate that there's a serious illness going on, and begin to establish, instead of a differential diagnosis for each of these things, a differential diagnosis for the condition of SIRS. If I have even more information and believe that this SIRS is due to microbial origin or an infectious cause, then I have the syndrome of sepsis. And if I have SIRS from a microbial origin and there's evidence of end organ dysfunction, decreasing urine output, metabolic acidosis, low platelets, and a PaO2 or FiO2 of less than 250, then I've recognized the syndrome of severe sepsis, which has implications not only for diagnostic etiology, but for therapy and timing of therapy. And similarly, I can move forward even more specifically to septic shock if I recognize after initial treatment that that severe sepsis is not responding to my initial administrations. This is summative processing. I've used only the example of septic shock. You'll work forward through some other ones during the homework this week. So, quiz 2.3. Processing is advisable because, number one, using medical terminology keeps patients guessing. Number two, it decreases the specificity of the patient's symptom. And number three, it activates memory stores and facilitates diagnosis. And the answer, of course, is it activates memory stores and facilitates diagnosis. Although it causes an abstraction of the patient's symptom, it increases the specificity with which we are able to identify possible causes that might be linked to that particular patient's presentation.